Hello class, in the advent of time and because we've already covered some of the content related to hypertension and fundamentals, I'm not going to specifically do a class time for that, but I wanted to give you a recording of that so that we can kind of focus on some of the things that are less familiar in the cardiac section for you. So this is just kind of an overview, so you can listen to this and kind of look and see related to your chapter 31 in the book as well, just to kind of refamiliarize yourself with some of the content. You want to know the difference between arteriosclerosis and atherosclerosis. Arteriosclerosis is where you have hardening of the arterial walls that comes about because of aging. So that's to be somewhat expected. Atherosclerosis, though, is typically a type of arteriosclerosis, but it is not so much related to aging as much as it is to plaque formation that is kind of occluding the internal area of the arterial walls. And here's just some pictures, and I've given you a little bit of information down in the content area there to look at. Ways that we really want to think about this is the worse this gets, then it kind of leads into lots of other cardiac problems along with hypertension, because the blood is now having to push against a more narrow opening. Interventions that are really best when someone begins to develop this, of course we want to, on an ongoing way, be looking at their cholesterol levels, their HDL and their LDL levels, and their homocysteine levels, which we talked about in class the other day. Paying close attention to nutritional therapy related to a low cholesterol, low fat diet, drug therapies that I'll show you here in a minute, and then smoking cessation is always key. Having patients kind of get back into a more ongoing, steady level of exercise to the level they can participate in is very important to kind of ward off this as long as possible and keep their fitness level as good as it can, even with this occluding in the vessels. And then, as we know about hypertension, the same thing is true for people who are under lots of stress, tend to kind of have this kind of thing go on as well. And we're not sure of all the reasons behind that, but having other types of relaxation and complementary alternative therapies that keep people calm and relaxed tend to be helpful in managing and maybe warding off this development of disease and complications from it. So, key things that you want to know, you can look at, there are a wide variety of statins that are used, and these are meant to lower bad LDL cholesterol. You want to raise the HDL to a normal level, and then you want to lower the triglycerides. And then fibrinic acids, they decrease triglyceride levels and also lower and raise the appropriate things for the other types of cholesterols, as we should. And then Zetia is a newer medication that decreases cholesterol absorption in the small intestine. So it's kind of used as not a primary drug, but more second, to kind of be done in with patients that tend to still have problems even though they're taking a statin or a fibrinic acid drug. So just make sure that you know the potential side effects of some of these drugs. Atorvastatin is one in the statins that you're going to see quite a bit of patients on, and it's somewhat common for patients to present and have some complications for that drug, probably more than even the others. So make sure that you look that one up and be aware of that. So you're going to see terms that talk about essential or primary hypertension, meaning that the cause of someone having hypertension is really resultant from the condition of arteriosclerosis and atherosclerosis, meaning that it's coming really from the vessels or this hyperplasia and thickening that is present. And over time, having severe primary hypertension can result in damage to the vital organs. And when you think about patients that you're checking their blood pressure, probably 90 to 95% of adult cases are going to be in this category. And we'll also talk about secondary hypertension in a minute, but the rest of the types of hypertension would be in that category. Common risk factors for developing hypertension. These are all some that you've seen over and over again and contribute to many chronic diseases. But cigarette smoking is one, obesity, again, a BMI that is equal to or greater than 30 is considered problematic. Physical inactivity, dyslipidemia, meaning that there is high levels of lipids in the blood or high cholesterol levels. Diabetes also contributes to this due to the glucose and the way it affects circulation negatively. Age, men greater than 55 and women greater than 65. Patients that have kidney problems, which we won't get into as much this semester, but the glomerular filtration rate less than 60. Sometimes you'll see that lab, or you might see micro albuminuria in the urine, and that gives you an idea that there might be a problem with this type of disease developing. Also, family history of premature cardiovascular disease, because we know there are some genetic factors to this. They've studied about 50 different genes already, trying to learn associations between developing hypertension and atherosclerosis, as well as other heart diseases. But age, when you have people in the family that were men that had early cardiac disease before age 55, or women that had cardiac disease problems before age 65, tends to be a risk factor for someone in their family then later developing hypertension. So those are the things that lead to hypertension, but what does hypertension lead to? So this ongoing poor circulation in terms of extreme pressure on the vascular system makes the condition worse and worse in terms of cardiovascular disease. And by that I don't just mean all the blood vessels in the body, but in particular too the coronary arteries that supply blood flow and nutrients and oxygenation to the heart muscle itself. And then we'll learn later when we talk about heart failure, hypertension is also a cause for that particular disease. Hypertension can also lead to stroke and also to kidney disease that we'll talk about more next semester. So your textbook has got old data in it, and I want to point that out to you because you want to make sure that you're studying your hypertension information in terms of actions based on the 2017 blood pressure guidelines. There is no more a category for pre-hypertension like your book has. These are the levels that are the most current, so make sure you go by these. Normal is less than 120 over 80. It used to be, I think, 130 over 90, and so they have changed that. And then elevated means that there is systolic between 120 to 129 and diastolic less than 80. Stage 1 is systolic between 130 to 139 or diastolic between 80 and 89. And then stage 2 is systolic at least 140 or diastolic at least 90. And then hypertensive crisis is considered systolic over 180 and or diastolic over 120. And this is when patients really need prompt changes in their medication and need, typically on an inpatient standpoint, IV medications to bring them under control because they can get into signs of organ damage because of that being sustained for long periods of time. So other changes include only prescribing medication for stage 1 hypertension. In the old system, that was where the level that you started patients on drugs. Now they can be given drugs earlier than that if they have previous cardiovascular events like a heart attack or stroke in the past, or they've had they're at high risk for heart attack or stroke based on their age, or if they have conditions that are chronic disease that are associated with increased risk for hypertension, such as diabetes, kidney disease, and then there is a calculation that they can do related to their atherosclerotic risk using a calculator based on having high cholesterols. So it's not just totally medication based on numbers anymore. These other factors are utilized by doctors to make that decision. And then other changes are recognizing that many people will need more than two or more types of medications to control their blood pressure. I think they usually used to start people just on one, and they might be on that for a long period of time and having it adjusted, and it might not get them under control. The key here is they really want to make sure that people get on what they need. So even if multiple medications are more likely to work, then get them on that. And if possible, finding medications that are contained 2 different types that will be in one pill, because that adds to the consistency of someone taking that regularly and not forgetting to take other dosages of separate pills. There's also a focus on identifying socioeconomic status and psychological stress as risk factors for high blood pressure that should be considered as part of their plan of care as well. So if you have patients that have settings that they're living or working that are making things worse in terms of these conditions, starting to really plan around how to impact those things, trying to look at other methods of interventions that might help them reduce stress in their life as an extra intervention beyond just medication control. Secondary hypertension, I mentioned before, makes up about 5 to 10% of adult cases. These are some of the common causes that you will see. And what it means by secondary hypertension is that they have a chronic disease like renal disease, that because the problems related to the circulation that are created because of the kidney disease then cause them to have hypertension. And that's because you have a renal artery there that affects overall hypertension. So we'll deal with that cause in particular and some of these other things like primary aldosteronism and Cushing's syndrome when we do more of the endocrine disorders in adult health too. But this is like a little link just so you can look at some of the causes and why those are secondary causes, or what it is about those particular diseases that make someone have hypertension, even though they may not have atherosclerosis particular to all their vessels. So how do we assess these patients? Of course, we get a big family history. We're looking again for those key risk factors like diet, lifestyle habits, genetic factors, what meds have they been on, what socioeconomic factors, and looking at are there any secondary causes that could be coming from the previous slide. Physical assessment, of course, we're looking at vital signs, weight, intake and output. Are they having any symptoms of heart failure? Because often heart failure may not ever be found until they're really already in the throes of it, because many people are not getting treated for hypertension early. Psychological assessment, again looking for stressors, and then diagnostic assessments, as we've mentioned already, looking at a lipid panel or profile, homocysteine levels, and then a complete metabolic panel to kind of look at electrolytes and kidney